This is the endocrine system part 3. Remember, go back and look at the objectives so that you'll be prepared to read and hear what is about to be presented. Now we're going to talk about cortisol. Cortisol is another steroid hormone from the adrenal cortex. It is the most important glucocorticoid that is in the body. A glucocorticoid is a hormone coming from the adrenal cortex that increases the concentration of blood glucose. So the source of cortisol is the adrenal cortex. The target organ or cells, meaning the regions where the cortisol works, are widely spread: liver, skeletal muscle, adipose tissue, to name a few. The effects of cortisol are very complex. They include regulatory effects on nutrient metabolism. Cortisol affects the metabolism of all three classes of nutrients: carbohydrates, lipids or fats, and proteins. The effect on carbohydrate metabolism is mainly an increase in the concentration of glucose in the blood. The effect on fat metabolism is that it stimulates fat breakdown. Cortisol also, however, inhibits the synthesis of proteins. The stimulus for secretion of cortisol is ACTH, or adrenocorticotropic hormone, which also is a stimulator of aldosterone, as you know. If you look at the effects of cortisol, it may look like that cortisol is a bad thing, that it's going to keep the cell from making proteins, it's going to increase the blood sugar. All of these things look like undesired effects. But what you have to remember is that the effects of cortisol and any other hormone, these are there for a reason. These hormones are there to maintain homeostasis, and the hormones all work in concert with one another. So cortisol doesn't work all by itself. It is present when other hormones are present. So you would have to consider the effects of all of the hormones that are in the bloodstream at the same time as cortisol to actually see the overall effect that cortisol has. You cannot live without cortisol. You must have it. You're used to seeing this slide by now, in which the left-hand box represents the anterior pituitary, the middle one, the target gland, the one on the right, the secondary target gland, showing hormones and effects that result from these hormones. So ACTH comes from the anterior pituitary, causes the adrenal cortex to release cortisol. Cortisol travels to several different kinds of tissues. In adipose tissue, it stimulates the breakdown of fat, or lipolysis. Diseases that involve adrenocortical hormones include Cushing's disease and Addison's disease. In Cushing's disease, there's too much cortisol being produced. The etiology or the cause of this condition can either be hypersecretion of ACTH by the anterior pituitary, or the condition may be in the adrenal cortex itself, a tumor that secretes too much cortisol. The symptoms of Cushing's disease, some of these you could predict based on what you know about cortisol. Cushing's disease causes hyperglycemia, and it can cause diabetes mellitus. Cushing's causes muscle weakness, hypertension, truncal obesity, which means the trunk of the body, the thorax and the abdomen, have an accumulation of fat deposited in the area. On the other hand, the legs are spindly, meaning the legs are thin. The face is usually very full, and there's frequently a mass of tissue at the nape of the neck that is called the buffalo hump, unattractively enough. The truncal obesity But the spindly, skinny legs that you see, it's easy to understand this when you remember the effects of cortisol on protein synthesis and on fat breakdown. So you have mobilization of fat under the influence of cortisol. Fat is going to come from the legs and deposit in the face and around the trunk. And the legs will also become spindly because they are not able to replace their proteins in a normal manner because of the increased cortisol effect. The other disease involving the adrenocortical hormones is Addison's disease. In Addison's disease, there's an insufficient amount of cortisol being secreted as well as aldosterone. So the two major adrenocortical hormones then are going to be deficient. You could predict some of the signs and symptoms of this as well. Hypoglycemia, meaning the blood sugar is too low. Generalized weakness, hypotension, imbalance of sodium and potassium, dehydration, weight loss, and a bronze tint to the skin. President John F. Kennedy had Addison's disease, and he had a bronze tint to his skin that most people interpreted as just a healthy tan. The adrenal gland is very much involved in the stress response. The stress response can affect the body on a chronic basis or on a more acute basis. I'd like to talk about the chronic stress first at the bottom of the slide. Chronic stress causes the anterior pituitary to release ACTH, which will cause the adrenal cortex to release cortisol, leading to, again, hyperglycemia, hypertension, and another effect that we haven't looked at yet, compromised or decreased immune function. So if someone tells you that, that you need to try to learn how to control your stress and what have you, there's a lot of good reasons for that, including the fact that chronic stress can cause you to be more susceptible to diseases. Acute stress is stress that happens on a more immediate basis. This is a type of stress that occurs and then it's over with. Acute stress causes different hormones to be released from the adrenal gland, including epinephrine and norepinephrine. I've listed epinephrine there mainly because that's the main one. Epinephrine comes from a different part of the adrenal gland, though. It comes from the adrenal medulla, the middle part. And epinephrine is the hormone that is associated with the condition of fight or flight. There will be more about this on a subsequent slide, but in fight or flight, briefly, you are preparing yourself to deal with a life-threatening emergency in which you might flee or fly away, run away from the danger, or you might stay and fight the danger for your life, the dangerous situation. It's interesting that the effects of acute stress are similar to those of chronic stress, including increased blood pressure and increased blood glucose. Incidentally, cortisol is also released during acute stress as well. There's another type of steroid from the adrenal cortex that I haven't mentioned. These are the sex steroids. Now, obviously, the gonads, the ovaries, and the testes are the main sources of sex hormones or sex steroids. However, a secondary source would be the adrenal cortex. The main adrenal sex steroid is called DHEA, which stands for dehydroepiandrosterone, which not only is a hormone, but it's also a very popular supplement that is accepted widely in the medical community as being a supplement that actually can do a lot of good in certain people. The source of the adrenal cortex then, the source of the DHEA and other sex steroids would be the adrenal cortex again. The effects of these steroids are supplementation of the sex steroids produced by the gonads. This especially comes into play in men as they get older, and women as they approach menopause and they after they have reached menopause, because the adrenal gland can actually maintain adequate sex hormone levels for a good period of time after the gonads begin to decrease their functioning and after the ovaries totally quit making estrogen at menopause. Other sex steroids from the adrenal cortex are mainly androgens, similar to testosterone, but certain estrogens are also produced by the adrenal cortex. Now, the adrenal medulla, the middle part of the adrenal gland, is a totally different type of tissue altogether. It secretes two hormones, epinephrine and norepinephrine. These are actually called neurohormones because not only do they travel through the blood to get to their sites of action, but they are also functioning neurotransmitters in which they're released by nerve terminals onto synapses. But during fight or flight, epinephrine and norepinephrine mainly are released into the bloodstream by the adrenal medulla. During fight or flight, the amount of epinephrine release is about 4 times the amount of norepinephrine release. By the way, epinephrine has another name that you may have heard of, and this is called adrenaline. Norepinephrine is called noradrenaline. You may not have heard of that one, but I guarantee you most of you have heard of adrenaline. You might think of someone having an adrenaline rush, meaning that they're able to do some kind of action or feat that normally they wouldn't even be able to do, but because they're in fight or flight and they have a lot of adrenaline or epinephrine rushing through the system, they have kind of sort of superhuman powers, I guess is one way to put it. So the effects of epinephrine and norepinephrine during fight or flight are increased heart rate, increased cardiac output, the amount of blood pumped per minute, increased blood pressure, increased blood glucose. It increases a lot of things. Increased respiratory rate, more oxygen pressure in the blood or content of the blood, increased blood flow to the muscle and other areas as well, including the brain. Finally, there's a decreased blood flow to the skin, and then increased mental alertness. Now, if one were trying to learn this little list, and actually the list has probably at least 10 more effects that could have been mentioned. At first, a person might think, how in the world would I ever learn these things? They don't seem to be related. But they actually are. If you ask yourself, what happens if I'm in fight or flight? And we've all been scared about one thing or another, or highly excited. You know that your heart beats very forcefully and your heart rate goes up. These will increase your blood pressure. You may not have known that you have increased blood sugar, but increased blood sugar does make sense on this basis. If you're preparing to either fight some adversary or run away from some dangerous situation, you're going to need increased energy to do that because your muscles are going to be working harder. Your brain's going to be having to think really fast. Your heart is having to work harder. So all of this muscle contraction, extra muscle activity, requires more glucose. And so luckily that glucose is available because of the effects of epinephrine and norepinephrine. Then the muscle cells are going to need extra oxygen. The brain cells will as well. And so this is accomplished by increasing the respiratory rate of the individual. The muscle is going to need the oxygen and the glucose. Like I said, the way the muscle gets it is through the bloodstream. So the blood flow to the muscle is going to increase. As I mentioned a moment ago, the brain blood flow increases, the myocardial blood flow increases, as well as skeletal muscle. So the decreased blood flow in the skin may not make a lot of sense, But if you think about it, it can actually make sense, and here's why. Because we just talked about increasing blood flow to three main areas: skeletal muscle, heart muscle, and the brain. If you're going to increase blood flow to certain areas, you're going to have to decrease it in other areas because there's only so much blood to go around in the body. And so one of the regions that doesn't need as much blood circulating to it at that time during fight or flight would be the skin. And so this is why when a person is really frightened, sometimes they'll be very pale in appearance because of the decreased blood flow in the skin. The increased mental alertness, I think I've already touched on that you've got to be able to think quickly to figure out how you're going to get out of the dangerous situation. Now we go to the pancreas and the hormones of the pancreas. The pancreas, we normally think of it as a digestive organ. 95% of the pancreas is digestive in nature. Only 5% is endocrine in nature, meaning 5% of the pancreas produces hormones. If you look at the anatomy for a moment, inspect the duodenum. The duodenum looks funny because it's normally attached to the distal end or the pyloric end of the stomach, but in this case the stomach has just been cut off away so that you can actually see the pancreas and the aorta and so on and so forth. Notice that the pancreas has a body and it has a tail. It also has a head, but that's not labeled. The head and part of the body of the pancreas lie in the curve of that C-shaped duodenum. Note the pancreatic duct coming from the pancreas into the duodenum. So, the pancreatic duct transports enzymes and other digestive substances to the duodenum, and so the duct is useful for the digestive process. For the hormones of the pancreas to get to where they're going, you know the story by now. Hormones are released into the blood, right, to go to their sites of action. So the pancreas has a very good blood supply then. You can see the aorta, and then the pancreas has a nice large arteries going to it, coming off the celiac artery. The inset to your right says the pancreatic islet of Langerhans. The pancreatic islets are the endocrine parts of the pancreas. These are clumps of cells from 4,000 to 5,000 cells each. They have several cell types. Two of the main ones are called the alpha cells and the beta cells. So we're going to take a look at those cells and their hormones. The islet cell type, called the alpha cell, secretes a hormone called glucagon, whereas the beta cell secretes insulin. And I know everyone's heard of insulin already, but we will talk about insulin in a moment. I need to show you the word glucagon for just a moment. You know very well by now that a lot of medical and scientific terms, at least some of them, tend to look like other terms, and you have to really know your business. You almost have to know how to spell everything exactly to be sure that you're not reading the wrong name and getting the totally wrong impression about what's going on. So the word glucagon is a hormone. The word glycogen is a storage form of glucose. So those words look very similar to each other. And glucagon affects the glycogen. So a lot of anatomy and physiology students or biology students tend to get glucagon and glycogen mixed up. So we don't want you to be doing that. So glucagon is the hormone. So we're going to talk about the beta cell product first, insulin. If you look at the effects of insulin, again, you could get overwhelmed by that little list. But first look at numbers 1 through 4. Those are short little descriptions, and then we'll go back and look at number 1 in more detail. The insulin has an effect on all three of the major classes of nutrients: carbohydrates, fats, and proteins, similar to cortisol, at least in that way. The effect of insulin on the blood glucose is that it decreases it. Insulin decreases glucose in the blood. Many students know this by the time they ever get into a class of this type. The effect on fat by insulin is that insulin causes more fat to be produced. That term is called lipogenesis. Another effect on fat is that insulin decreases the breakdown of fat. So insulin increases fat formation, it decreases fat breakdown. Both of those are going to be pro-lipogenesis or pro-fat, I guess I should say. Finally, insulin increases protein synthesis. So proteins, lipids, and carbohydrates are all affected by insulin. Now we want to know a little bit more detail about how insulin decreases the concentration of glucose in the blood. There are several ways, but two of the main ones are that insulin causes glucose to be taken up into certain cells: adipose cells, muscle cells, and liver cells. For those three types of cells, if insulin is not present, those cells cannot take glucose up into them, and so those cells will literally starve in the presence of high concentrations of glucose. If there's no insulin available, the cells just cannot take the glucose up. But in the normal situation, with insulin present and stimulating those cells, glucose will enter those cells and leave the blood, thereby depleting the amount of glucose in the blood, I guess you could say. Another process in which insulin affects the carbohydrate metabolism is that it increases the formation of glycogen. So there's that word. Glycogen is that storage form of glucose. Insulin stimulates the formation of that substance. That process is called glycogenesis, or the formation of glycogen. The main regions of glycogenesis in the body are the liver and skeletal muscle. And we've already identified liver and muscle cells as being highly insulin dependent. The stimulus for secretion of insulin, the main one is a rise in the concentration of glucose in the blood. I said the main one, although you might have thought it was the only one, but other nutrients can rise in concentration in the blood and also stimulate insulin release. The increase in blood glucose normally occurs after a meal, so insulin secretion is going to be highest right after a meal. There's another hormone that will be presented here in just a moment called glucagon. Insulin and glucagon are counter-regulatory to one another, which means that if one of them increases something, the other decreases it. So insulin is going to decrease the concentration of glucose in the blood, while glucagon increases it. If a person is fasting, or if it's during the night or between meals, insulin secretion is knocked down to basal levels, but glucagon will rise to maintain the blood glucose. So glucagon is a product of the alpha cells of the islets of Langerhans. The effect of glucagon is the opposite from insulin. Glucagon increases the concentration of glucose in the blood. The stimulus for its secretion is a decrease in blood glucose. What I mean by that is, and I said this a moment ago, let's say that you ate a meal 2 hours ago. Your blood sugar will start to drop and would drop to a dangerous level, except that glucagon will be secreted and it will keep the blood sugar at a constant level to keep you going until it's time to eat again. So glucagon keeps you going between meals. Insulin is going to be important shortly following a meal. The stimulus for secretion of glucagon, then is a decrease in the glucose concentration. Typically that occurs in the fasted state or through the night. The homeostasis of blood glucose is a little more complex than this, but this slide does it justice pretty well. If you look at the red box at the top of the slide, you'll see there's an increase in blood glucose level because the person just ate. The pancreatic beta cells will increase their insulin secretion, which causes cells to take glucose up into the blood. These cells particularly are the liver and muscle cells, adipose tissue cells, liver, certain other types of cells, but these are the main ones. So as glucose enters the liver and muscle cell and the adipose tissue cells, the blood glucose level is going to decrease. So if you look to your right, the other pink box, you see a decrease in blood glucose following the uptake of glucose into the cells. This decreased blood glucose is sensed by the pancreatic beta cells, and they're going to shut off their insulin release to just the normal basal activity. Of course, the main disease we think of when we think of insulin is diabetes mellitus, abbreviated DM. There are two common types of diabetes mellitus, although there are several others in addition. We'll just talk about two of these at this time. Type 1 diabetes mellitus means that there is no insulin at all being produced, an absolute deficiency of insulin. The pancreas makes no insulin. This affects about 1 million people in the U.S. In type 2 diabetes, there's insulin available, but it's just not enough. So we say that's a relative deficiency of insulin. There's insulin there, it's just not enough to meet the body's needs. About 29 million people in the U.S. have type 2 diabetes. About 15 years ago, there were 15 million people in the U.S. with type 2 diabetes, so that number has almost doubled in 15 years. It's kind of scary. In type 1 diabetes, the underlying problem is what we call an autoimmune destruction of the beta cells. Autoimmune means that the body produces antibodies that will destroy its own healthy tissues. Clearly this is an abnormality, but that's exactly what's going on. When the beta cells are destroyed, then they can't secrete insulin anymore. The symptoms and signs of type 1 diabetes include what we call the 3 polys: polyphagia, polydipsia, and polyuria. Poly means increased or many. Polyphagia is increased eating. Polydipsia, increased thirst or drinking. Polyuria, increased urination. So these are the 3 hallmark signs of uncontrolled type 1 diabetes. Another very common and important sign is fatigue, and then of course hyperglycemia. The blood sugar gets out of control. At certain times the person may have a sweet or even fruity odor to the breath. It also smells a little bit like acetone, if you know what that smells like. This is in the person whose blood sugar is really out of control, such that they're breaking down significant amounts of fat just to keep their cells metabolizing, and breakdown products of fat have that characteristic smell to them. The individual will have confusion. They can go into a coma called diabetic coma, and they can die if the diabetes or the symptoms are not treated after a certain amount of time. Now these symptoms are mainly prevalent in someone who is not being treated yet for their type 1 diabetes, or someone who they know they have diabetes but they're not taking their medicine right or something like that, their insulin. But once the individual gets on insulin and they're well regulated, then a lot of these symptoms will go away. It's just they have to take their insulin every day and take it the way they're supposed to. In type 2 diabetes, the exact cause is not known. There's known to be a strong genetic component, which means that the tendency to develop type 2 diabetes is inherited. Incidentally, type 1, the tendency to develop type 1 is also has a strong genetic component, but not nearly as significantly as type 2 does. 90% of people with type 2 diabetes are obese, with only 10% being of normal weight or thin. The primary defect in type 2 diabetes can either be in the pancreas itself, or it can be in target cells in the liver, the muscle, the fat, and that's called insulin resistance. A lot of the time, both of the defects are there. The pancreatic and the target cell defects are there. The signs and symptoms of type 2 diabetes are all of those for type 1, except for the fruity, sweet odor of the breath. And the reason for that is that because there's some insulin available, there's even in most type 2 individuals, there's plenty of insulin to keep the person from having to metabolize their fat exclusively for cellular needs. I think it's instructive to look at the old terminology for the two types of diabetes. Type 1 diabetes was once known as juvenile onset diabetes or insulin-dependent diabetes. Type 2 was formerly known as adult onset diabetes or non-insulin dependent diabetes. Here's the thing. You don't have to be a child or adolescent to be diagnosed with type 1 diabetes. A lot of people are diagnosed in their 20s, 30s, and even beyond. Another thing is that many of our type 2 diabetics actually require insulin, so the term IDDM or insulin-dependent diabetes is also not totally relevant just to type 1. Type 2 is not just adult onset anymore. In fact, most of the type 2 individuals being diagnosed today are actually children and adolescents. This is something that you almost never saw back 40 and 50 years ago. And then again, non-insulin dependent diabetes describes some of the type 2 individuals, but certainly not all. So the best terms to use are type 1 and type 2. No matter which type of diabetes an individual would have, the long-term complications of the disease are identical in both types. Atherosclerosis is one of the main complications of diabetes. What that means is it's deposition of cholesterol deposits in the arteries. This can lead to many, many different problems. If the arteries affected are in the heart muscle, heart attack can occur. If it's in the brain, a stroke can take place. If it's in the extremities, like the legs, that will result in poor circulation to the legs. It can cause gangrene, where the tissue begins to die and can result in amputations. Diabetes can ruin the kidneys. This disease is called nephropathy, meaning kidney disease. It can lead to kidney failure. So therefore, a lot of diabetic individuals end up on dialysis. The diabetes can affect the eyes. It can cause cataracts, and it also can cause blindness due to a condition called retinopathy. Diabetes damages nerves, which can lead to several different problems. It can lead to pain in the extremities. It can lead to decreased sensation in the extremities. And the risk of that is that an individual can cut themselves or have a wound of some type on their foot or ankle, and they may not even realize it. So therefore they don't treat it. They're not careful with it because they don't know that anything's wrong, and a serious infection can set in before the individual even realizes there's something wrong. By then it may actually be too late to save the foot. I mean, this happens a lot. So neuropathy is a very dangerous kind of situation. If the nerves being affected are in the autonomic nervous system, other problems can occur, such as impotency in men or gastrointestinal problems, including one called gastroparesis, in which the stomach doesn't empty in a normal fashion. The food may stay in the stomach for 4 to 6 or even 8 hours, resulting in nausea and vomiting and just a general terrible feeling all over for that person. The last hormone I want to talk about is a hormone from the kidneys. The hormone is called erythropoietin, or we commonly call it EPO. EPO is not only a hormone, but it's also a drug. It is used in people who are taking cancer chemotherapy sometimes to build up their red blood cells. It can also be used in individuals who have had kidney failure. When the kidneys fail, that doesn't mean that it's only an effect on the urination, but kidney failure causes other problems in the kidneys as well, including decreasing or even stopping erythropoietin secretion. So let's look and see what erythropoietin does, and we'll come back to that. The source, of course, is the kidneys. The target tissue of EPO is the bone marrow stem cells, particularly the cells that produce red blood cells. So EPO effects is that it stimulates erythrocyte production, or red blood cell production. Here's the stimulus for secretion of EPO. It's called renal hypoxemia. Renal means kidneys. Hypo is below. Ox is oxygen. So renal hypoxemia means a decreased oxygen level in the blood vessels, of the kidney blood vessels. So if you think about it, it kind of makes sense, because the oxygen pressure or content of the blood drops below normal. The hormone is released. It causes the bone marrow to make more red blood cells so that more oxygen can be carried by the blood. Now, this is not going to be an immediate effect. If the blood oxygen concentration drops, it's going to take it hours to days for the EPO to be secreted, to travel to the bone marrow, and to start really producing an effect. But that is the way that that's controlled. Erythropoietin has been used, and probably still is in certain instances, illicitly by some athletes, because in certain sports the ability to transport more oxygen than normal to the cells would confer an advantage to those individuals. And of course this is outlawed by the Olympic agencies and agency and NBA and various sports organizations and so on and so forth. But I think people are still kind of trying to get by with that, and it really does give these people an advantage. It has some long-term ill effects, though, just like a lot of other medications and hormones that have been abused, and that is that erythropoietin can increase the red blood cell level so high that the red cells will actually clog up capillaries, and it'll almost cause something similar to sickle cell anemia, or at least it feels like sickle cell with the painful extremities and what have you. EPO, at first, when athletes were abusing EPO, it was kind of hard for authorities to figure out what was going on. The reason is that since EPO is a hormone produced by the body anyway, it was difficult to, it wasn't known exactly what the normal levels of EPO were in the body. It turns out that you and I might have fairly different levels of EPO in the blood that would be normal for us, you see. So first of all, they had to establish what is the normal range of concentrations for EPO in the body. Once they figured that out, then they could begin to say, okay, if an athlete's blood concentration of EPO is above this level right here, we're going to have to investigate them to because we suspect that they are abusing EPO. So the science has come a long way since then, but at any rate, I thought you'd be interested in that one. So with this, we're going to conclude our study of the endocrine system. There's a lot more that could have been said, a lot of other different hormones, believe it or not, that we haven't even talked about. But on the other hand, this gives you a really good background, and hopefully it will help to clear up some questions you may have had along the way. I hope you found it interesting, and I thank you for your attention. I want you to study hard. That's it. Next slide. The end.